All right, y'all, we'll get started. Thank you for crawling out of bed this morning, getting your coffees, and coming to join us to talk about challenging conversations when time is always tight in the emergency department. And we're going to be talking about 3 communication frameworks that can help us out. My name's Gretchen Fuller. I am an emergency medicine physician and pediatric emergency medicine physician here at UT Austin. And outside of my clinical work, I also do mostly communication skills training in healthcare. So I'm the Assistant Director of Patient Experience at USACS, and I'm a faculty member of an organization called the Academy of Communication in Healthcare.
Good morning. Thanks for joining after Superstition, like we said. My name is Greg Wallingford. I'm emergency medicine trained, now palliative care doc. So some of these skills, and really like the alternate title here, I think could be simple tools I wish I had when I was in the emergency department. So what we're going to be going through today are just some really quick hits on frameworks that you can use when you feel like you're walking into a more difficult conversation or one turns difficult.
So think back to the last shift that you worked where emotions were running high, perhaps your own, or the patient or a family member's, or maybe someone that you're working with. Or time felt short and you felt really rushed. Or you felt like you were about to have an uncomfortable conversation, or maybe, ooh, did I just say the wrong thing? And the reality is, this is probably not thinking back too far. It's probably almost every shift that one of these things is happening. And the reality is, I can think back to just the other shift. I was working at a community site, and a 50-year-old guy is boarding for hours for chest pain. His wife comes in yelling at the whole department, saying, I'm going to leave AMA with him because y'all, if he's just sitting here, like I can take better care of my husband at home. Like he hasn't even been able to eat anything. He's hungry. He hasn't gone to the bathroom. Like he has to pee. Like no one's even watching him here. He was even off the monitors. He could have coded and I could have done CPR on him. So in that moment, I noticed, blood starts to boil a little bit. The staff starts ramping up their emotions. And in that moment, I actually noticed, though, I'm okay because I've actually spent a lot of time now working on communication skills, and I look forward to interacting with folks in this space and trying to kind of like hear their story and kind of get to the bottom of this and calm. But it takes some skills to get there. And the reality is that we talk a lot about clinical knowledge skills, but a lot of the things that cause some stress in our daily lives are communication challenges. And communication is actually the procedure that we practice most commonly in emergency medicine, but we don't typically approach it the same way that we approach putting in central lines or intubating a patient. We don't have the same training for it. And these skills are teachable. So that's what we're hoping to cover 3 quick skills today that are teachable skills that you can employ right now in your next shift. We're going to be covering 3 objectives today. We're going to be talking about shared decision-making, naming and legitimizing emotions, and practicing a framework to help us disclose bad news or difficult news. We'll start with shared decision-making. And let's start off with a case. You're seeing a 26-year-old male who's presenting for abdominal pain that he's been having for a few hours. On his exam, you notice some non-specific, pretty mild mid-abdominal pain, and his vital signs are normal, and the only thing that's abnormal in his blood work is a white count of 13. And he initially came in thinking that he needed a CT for appendicitis, but when he was told this might take a few hours in the emergency department, he's now saying he's feeling better and he wants to go home. So what is shared decision-making? Shared decision-making is when you, the clinician, present and describe various management options that are all medically reasonable and get the patient's input on what they feel is the best option for them. You really need to communicate concisely 3 different things, and that's what the options are, why they are reasonable, and what the patient's perspective is on those options. So thinking to our 26-year-old male, this is an example of using a framework that Greg and I call the some people, other people framework to present some shared decision-making options. So you could say to this 26-year-old male, some people tell me that they'd rather avoid the radiation and go home right now, even if there's a bit of uncertainty about the possibility of appendicitis, and you can always come back if things get worse. Other people tell me that they'd really like to get a more definitive answer while they're here, even if it takes some extra time and exposes them to radiation. What are your thoughts? You're going to practice this right now with the person sitting next to you. So you have a 5-year-old that's coming in with a closed head injury after a scooter fall. The patient vomited once and otherwise has a normal exam and behavior, and per PCARN guidelines, you're recommending observation. The mom looks intensely nervous, though, about the fact that their kid could have a head bleed because her friend's kid suffered a head bleed when they had an injury recently from a fall from a bicycle. So how could you, with the person sitting next to you, use the some people, other people framework to initiate a shared decision-making conversation about observation versus CT? And take about no more than 1 minute to have a conversation with your partner about how you might use some people, other people to have this conversation. Mm-hmm. Yep. Yeah. I have a minute on. About 20 seconds left. Oh, perfect. Okay, perfect. Yeah, I'm just going to move forward. I'm not going to ask for this one. Maybe at the end. Yeah. Time? Okay. All right, it's okay if you guys didn't finish your conversations. One possible option that you could have said is something along the lines of, some parents prefer to have us observe their child in the emergency department as their risk of serious injury is really low, in fact, under 1%, and their risks of having a CT scan. Other parents say they're not going to be able to stop worrying about their child, even after a careful observation period, unless they have a definitive answer, even if the risk of serious injury is really low, and even if it means radiation exposure for your kid. What are your thoughts? And so notice that this hits all of the components of shared decision-making, which is offering the options, explaining why they're reasonable, and asking the patient's perspective. And those are the three things that you're really wanting to hit. With this some people, other people framework, people notice that it's a pretty easy way to frame and legitimize other options, and it actually happens pretty quickly. And also it's an effective framing, legitimizes the options, like I mentioned, and invites the patient perspective then at the end. We'll move on to Greg's part.
All right, so here's something that I was terrible at when I was in the emergency department. Something we've spent a lot of time on in palliative care, but I think is really like a 2-second skill when you use it. So it is about naming and legitimizing emotions, which we hear all the time, and they're always wrapped up in more cognitive statements like, there must be something else you can do, or I can't believe I don't have an answer. So starting with the case again. So a 24-year-old female presents with 6 months of generalized abdominal pain, comes and goes. She was supposed to go to GI clinic. It was canceled, so she came to the ED instead. We had this all the time when I was in the ER. Essentially, her exam and labs are unrevealing and normal. Right when you're about to discharge her, mom runs in and says, "This has gone on for too long. There's got to be something wrong, doctor. You had better give us answers." So here's what I might have said in my past life. I'm so sorry the GI doctor canceled on you today. We didn't find any emergencies on our workup. We do recommend that you follow up in the GI clinic. So we are giving here a cognitive response and plan to an emotion. And so the studies demonstrate that we think we're a lot better at conveying empathy than we actually are. Numerous studies demonstrate this. But there's good reason for it. There are several barriers to why we have a hard time naming our patients' emotions or even our colleagues' emotions. And I'll give 3 examples of why that might be. One is that we're worried we have to fix what is commonly a negative emotion that our patients are having. People come into the emergency department with fear, anxiety, sadness, grief, and we're worried we have to fix that emotion. The reality is that we don't actually need to fix negative emotions. A second reason why it's really hard for us to name emotions and respond empathetically is because we're socialized to stay professional and to talk about
clinical knowledge, and that getting into matters of the heart might feel a little vague or uncomfortable. And the reality is that when patients are asked what they care about most in their clinicians, empathy is one of, if not the most important things that they mention that they care about. So it matters to our patients, so it should really matter to us. And then the third thing is that we worry that when we're entering this emotional realm, that we're gonna like open Pandora's box, or like, a whole can of worms gonna be open. It's gonna negatively affect our empathy. And actually, studies have shown that responding with an explicit, verbal, empathetic statement shortens visits. Now, these studies were done in the outpatient setting, but this is because when someone has emotional distress, they keep cycling on it until it's addressed. And so it can save you time. You don't need to fix the negative emotion, and you actually are doing something that the patient cares almost most about in their medical stay.
So one thing we'll be talking about just in this response, and like I said, that was the one I might have given prior to thinking about this, is just using a more specific word than sorry. So some research on this. So there's this thing called amygdala hijacking. The short version of this is in business literature, management literature, neuro literature, and they recently, like a decade ago, did some fMRI studies that all kind of prove this same thing out, which is that when our amygdala is firing, so our emotions are high, we cannot think cognitively about decisions, which is what we need to do in the emergency department, is help them make a decision, help make a disposition, et cetera. And so actually the most powerful tool to turn that amygdala off is actually to name the emotion. It's called affect labeling in the literature. It shows up on fMRI studies where the amygdala is on, the frontal cortex is essentially off. The amygdala turns off when you name that emotion, and the frontal cortex turns back on. So what that really means is that you help people think when you name their emotion. So what emotion might this patient be feeling? This has gone on too long, doctor. There must be something wrong, and you had better give us answers. I'm putting one up here that I think is reasonable. You don't know exactly what they're thinking, but you say, gosh, it must be so frustrating to have pain that's gone on for a year without anything to pin it on. And pause. So in the ED, right, our instinct is to run all the time. And I think sometimes we run through these, but the pause puts an exclamation point on it and also allows a simmer down period. It's got to be so frustrating. I'm so sorry that we don't have an answer. You have been multiple times to the doctor, and I don't have anything, else that I can add diagnostically. Pause. So the second part of this, so you name the emotion, but you also need to legitimize it. So you call it out, but then say why. So it's really frustrating to have pain for so long and not have answers. I can see how much you care about your daughter and your daughter's health. Would it be okay if I shared what we did today? And I'd be curious to learn what you're most worried about. I don't know, that took me maybe like 7 seconds, let's say. I bet that shortcutted like 2 or 3 minutes of conversation and probably made the patient and daughter leave a lot happier.
All right, so we're gonna move to practicing this. So we have 3 drills in which the only task that you have is to name the emotion in a sentence and pause. That's the only task that you have at hand. We're gonna do 3 quick cases. So a patient that's been on hospice care arrives after a family revokes the hospice in the setting of a sudden decline in their health. Has anyone seen this happen in their ED? Okay. They arrive and the family member states, I don't know what to do. He doesn't even wanna be here. Turn to your partner and just say, what's the emotion? Name it in a sentence and pause. All right, what were some of the emotions that were named in your groups? Worried. Okay, I hear worried. Scared. So, Greg, I'm going to be the family member now. Why don't you respond to me? I don't know what to do. He doesn't even want to be here.
It's got to be so overwhelming with a family member so sick and not knowing what to do.
Exactly. Okay.
All right, drill number 2. Flip partners, so whoever was responding, it'll be the other person this time. So a patient with abdominal pain has a normal CT scan and an otherwise normal workup, and you're planning for discharge. You go into the room and the patient tells you, this is useless. Y'all don't even know what you're doing here.
What emotions are you naming here for the patient's family member? What might this person be feeling? Frustrated, I hear? Yeah. Fearful. Oh, I love that one.
Well, this was useless. Y'all don't know what you're doing.
And it sounds like it might be pretty frightening to have symptoms that we're not sure what the cause is. All right, last one. A colleague returns from a cone. Note that we just did 2 patient examples, or a patient family member, and now we're actually going to do a colleague. This works with colleagues too. We all have emotions, right? So a colleague returns from a code. Oh, yeah.
Really quickly jump in to say that this is actually me. I just want to point that out. Like in real life, this was me back. Yeah.
So Greg returns from a code where a patient died. He blankly looks at you and says, I can't believe that vague chest pain was actually an aortic dissection. Turn to your colleague, and what are the emotions here?
Anyone want to call him out? I heard one. Shock, I think I heard you say. Anyone else? Overwhelm, unsettling.
So, guilty.
Absolutely.
Yes.
Shame is so common in medicine.
Yeah. So, Greg, I can't believe that vague chest pain was actually an aortic dissection.
It's got to be shocking to have these vague symptoms show up as the thing that you're supposed to detect on arrival at the ED.
All right.
So this one's near and dear to my heart. This is like the one line that I think has gotten me like 30% of my entire fellowship training in palliative care. And I'm sharing it with you here, so you are 30% fellowship trained right now. Did you, Matt? So we're going to get to it, but the short version of this is it's a framework to disclose bad news that aligns you with the patient. Case, 64-year-old with severe dementia, trach and peg, recent large stroke, presents with severe sepsis and concern for aspiration, and this is the 4th time you're seeing him in the ED in 6 weeks. The patient's partner states to you, tell me what's going on, I don't want her to suffer. So here's the framework. I hope, I worry, I wonder. I'm going to say it a few times just so y'all remember it, because I think you can take this back to the next ED shift probably somewhere. I hope that we can get her through this episode of pneumonia, aligning with family. I hope we are on the same side. I am on the same side as the patient. I want it to get better too. I worry that this is going to keep happening, right? This is the 4th time in 6 weeks. So you are sharing hard news directly. I worry this is going to keep happening. You're not, oh, maybe we'll get through this, right? You're saying, I am worried this isn't going to go the way that we think. But it sounds very much patient aligned because it is. I wonder if you've thought about what she might want if we couldn't fix the reason she's having these pneumonias so often. Okay, so let me just back up and do it all at once because it's very quick and I think it's usually very effective. I really hope we can get her through this episode of pneumonia, but I am so worried. This is the 4th time, and I worry this is going to keep happening. I wonder if you've thought about what she might want in a situation where we can't stop this from happening again.
Note the pause at the end of that. It's important to leave space for a response there.
So here's your practice. I hope, I worry, I wonder. You're caring for a 44-year-old who reports uncontrolled abdominal pain in the setting of stage 4 metastatic cancer. She's failed 3 lines of chemotherapy and is screaming in pain. You give her pain meds and she starts becoming sedated. Her family asks you, Doctor, I don't know what to do. Turn to your partner. Take a few seconds to collect your thoughts. I hope, I worry, I wonder. All right, here's a possible response. I bet that some of y'all said some of these things better than is written up here, but just this is a suggestion. So, I wish your wife's cancer was curable and her pain were controlled. We had hoped we could find a good medication plan that would keep her both comfortable and alert. I worry she's dying from her cancer and that she's uncomfortable because we're holding pain medicines to keep her alert. I wonder if more aggressively treating her pain, even if it means less time alive, would allow her to die comfortably and peacefully. Again, so you've taken like an entire goals of care conversation that usually would come in pieces with information like, well, you know, we can't give her more pain meds, or we can, but like if we do, I just want to let you know that there's a risk of dying. You know, those conversations are both long and clunky. This probably took me, I don't know, again, like 20 or 30 seconds, and I think it gets you like 70% of the mileage of like a much longer conversation. So I think if I, again, had to repeat this framework one more time, I hope, I wish, I wonder, this is really like most of the magic of getting an ER goals of care conversation, ER disclosing of bad news. And if you need more, it's probably time for a palliative care consult, because the longer version of this is like 30 minutes. All right. So today, 3 goals. Number 1, some people, other people for shared decision making. Number 2, when you hear a cognitive statement that feels hard, take 1 second to say, is there an emotion behind this? And if so, can I name it? And I think that one tool to name emotions if you don't really know, instead of saying I'm sorry, which feels kind of token, so you can say something like, this is really tough. And people will usually name the emotion for you. It is tough. I've been waiting for 6 hours, doctor. And you hear, they're impatient. So you can get the emotion by naming just the general feeling of like, this is hard or tough or difficult. And then this I hope, I worry, I wonder framework.
Thanks. I think we have a few minutes for questions before the next. Oh, yeah.
Do you just, So last shift, patient came in with a plan. They had trigeminal neuralgia, and they said, the last doctor I went to a freestanding, they said, you guys will admit me to get my pain under control. And so, she was there with her mom, and this was their goal, which was to be admitted for pain control. And that was not my goal.
So this is a really great case, and this is an example of actually when several of these tools can be utilized, namely the naming emotion and legitimizing it, the second thing we talked about, and also it's actually disclosing bad news to the patient too. So it's an I wish, I worry, I wonder statement. Do you have any additional
do you want us to try?
Yeah, okay.
So, is this working?
Yeah.
Okay, sorry. Well, first of all, I can't imagine how frustrating it must be to have a painful diagnosis with no treatment, be told to come here for a treatment that I'm not sure that we're going to be able to offer today. Not because we don't want to, but because we're not trained to do that procedure. I really hope that with some medications today, we can get your pain under better control. I'm a little worried that the treatment you need isn't something we can do here in the ED, but I can set you up with some resources to hopefully address it. I wonder if you have any ways that you've been told to reach out more urgently to a neurosurgeon. We can try to do that here too.
Yeah. And I love a lot of the components of what was in your statement. Things that I heard were naming an emotion and legitimizing it. So you're saying it must be so frustrating to have a painful condition for so long and to have a unmet expectation of coming here and expecting to be admitted, and now I'm saying you might not be admitted. Important part here is pause now. What do they respond with? And then moving on to
There's often, you'll realize too, if you name the emotion, just let it sit, people will name things that you never expected. They might say, oh my God, I'm just so worried it's cancer, right? And you never know that's coming until you kind of let it sit.
Or I have a big work presentation tomorrow. There's no way I can do that. And like what they really wanted was like a work note or something. So there's like, when you let it sit and allow space to expand, there's usually other ways that you can align with the patient and be like, I wonder if there's other ways that we can work together, which is a statement of support, which is something we didn't talk about. I wonder if there's other ways that we could work together to figure out a really good plan, a safe and effective plan.
And there's obviously a lot of other communication tools. I was trying to just illustrate like the 2 ones that we use today to try to answer a question like that. But that's tough.
Yeah.
That's absolutely tough. And that is what absolutely, I'd point out what Gretchen said. Bad news sometimes means we're not giving you what you think you're getting here.
We had one of our cases that we were going to talk about was like someone that comes in asking for a GI consult, and like that's not going to happen at Seton, Maine, right? So if they're not actually like bleeding, and it's like, right. And so I wish that I really wish that, or like I'm hoping that we can help control your symptoms today. I'm worried that we're not going to have a GI consultation coming to the emergency department because they have very strict requirements for when they come in. I'm wondering if we can work together on a pain management plan and follow-up plan that will allow us to help your symptoms and make you feel like you have a good follow-up.
I think we better hand off for the 8:30.
Thank you all.
Thank you so much for coming.